health, healthcare, health insurance, and our community. The problems locally are the healthcare and insurance costs are increasing too fast and too much. Fewer people are insured, and fewer are receiving care. There's less local and personal service, and less consumer voice. So how can we control care and costs in our community? How much does healthcare and health insurance really cost? In 2009, the amount that was spent on health costs and health insurance represented 17% of the gross domestic product. And $17 out of every $100 earned and spent in the country went for health care, up from 16% in 2008, or 1% increase per year. The Council of Economic Advisors on the federal level has projected that by the year 2040, $35 out of every $100 earned and spent will be spent on health care. Locally, the Dartmouth Institute estimates that health care costs in the Upper Valley will equal 25% of all monies earned and spent by the year 2017 in the Upper Valley. Who's insured, and by whom? Well, 59% of all the people insured in this country are insured by employer-sponsored health insurance. 59%. One of the things that's happening nationally is the smaller employers are dropping health insurance coverage, while large employers with more than 50 employees, almost nearly all insure their employees. Only 43% of those with 50 or fewer workers actually offer insurance. Again, the federal projection is that by the year 2040, that number will drop from 43% to less than 20%, or cut the number of insured employees by half. How have deductibles changed? This slide shows that between 2007 and 2013, there was a significant increase in cost to the employee. In 2007, roughly $2,800 was spent by the employee to pay part of the premiums and to pay the co-pays and deductibles. That number changed from $2,800 in 2007 to $4,800 in 2013. How do wages and inflation compare with the cost of health care? Between 2001 and 2006, just before the recession, wages and inflation increased between 17 and 19%. During that same time frame, health insurance premiums increased 78%, more than 4 times the rate of inflation. Over a 10-year period, looking at the price of drugs, hospitals, and doctors, you can see that the increase in actual costs for drugs, hospitals, and doctors was about 75% increase. During the same period, a 10-year period over a 10-year growth period, the cost of insurance premiums went up 113% compared to the 75% for the actual cost of health care. So 38% was retained by the insurance companies that was not spent on the actual health care costs. The result is that the growth in family health coverage and health insurance costs has grown significantly. The bar graph indicates that by the year 2011, the cost was $19,000 for a family plan. That has increased further, so that now in 2013, that cost is $23,000. And that compares with a cost of only $9,000 in 2002. So in 11 years, the cost has more than doubled. What makes up health care costs? This simple pie chart shows that the largest part of the cost goes for hospitals and specialists at 45%. The second largest piece of the pie is primary care. That's the family doctor and all the related services at the family doctor's office. The third largest piece is for drugs and pharmaceuticals, and the fourth is for administrative costs, including insurance. So what can we do to control health care costs? And in particular, what can we control locally? Well, we all engage actively in the purchase of drugs and visiting our family doctor. Many of us are involved with purchasing of insurance. Those are all factors we can deal with as individuals at a local level. Those costs, the cost of drugs, represents 14% of the total cost of health care. Cost of primary care is 30% of the total cost, and the administrative costs, including insurance, represents 10%. So that's a total of 54% of all the costs in the healthcare system are things which are directly under our control at the local level. So how do we control pharmaceutical costs? Well, the best way is to use group bidding. By doing that, costs can be cut up to 75%. That 75% savings equals 11% of the total healthcare cost. How can we control administrative costs? We can make sure that our insurance is paying for the care of people and for wellness, not for specific functions. We can increase coordination to reduce duplication of effort and to make sure that we're effectively and efficiently using staff and systems, and also because of the coordination to make sure that we prevent mistakes. So how can we control insurance costs? Well, the first way is to spread the risk over a longer period, which means more age brackets are insured by the same policy. Typically, insurance policies run 1 to 3 years. Using a longer period of 3 to 5 years, you'll have a broader range of ages that are insured. The second, and perhaps the most important piece, is to make sure that the savings that derive from these efforts are kept by the ratepayers and not by the insurance company. The third is to actively manage fraud to prevent excess claims on the insurance policies, and to work for tort reform to make sure that unnecessary suits aren't brought. So how can we manage primary care cost and quality? Note that it's both cost and quality. On the cost side, we can help to manage the physician and support staff costs, make sure that equipment and buildings are fully utilized, make sure that we've reduced costs for liability insurance and use bulk purchasing, and keep the debt service low to keep the cost down. On the quality care side, we can make sure the care is effective, that it's comprehensive for all the people in the family and for all the illnesses which are addressed on a family doctor basis. Make sure that there's full communications between the patient and the professionals, and that the professionals stress wellness and work to prevent repeat incidents or repeat visits for the same problem. There's a term for this type of care. It's called a federally qualified health clinic. It has that distinction because it's 1, accountable to the patients, 2, offers high-quality care, and 3, has cost containment and offers cost-effective service. What follows is an example of a rural federally qualified health clinic in Vermont that was created in 1975. It serves the entire community, and the community is actually 6 towns in central Vermont with a total population of 12,000. We show this as an example to show that it is possible for us to structure our health care in similar ways so that we can make the same savings that these folks have done. On this federally qualified health center, it's local, it's comprehensive, it offers quality service, and it's personal. In a center like this, the docs have all the privileges that you usually would find at local hospitals and regional hospitals. It doesn't affect our insurance policies for hospital and specialist coverage or out-of-region coverage. And there still would be choice. Anybody could go where they like to for primary care. But frequently with this system, choice has a price. So as long as people use quality service and cost-effective service, the price is much lower. In a system like this, savings can equal 50% of the primary cost, which equals roughly 15% of the total health care cost. In this sample, what's offered? Well, it has 14,000 registered patients. On an annual basis, it usually sees about 9,000 of them. It's open 60 hours a week and offers full primary care service with 4 full-time doctors and 6 physician assistants. It has 9 dental chairs with 4 full-time dentists, dental hygienists, and mobile dental service for schools. There's a low-cost pharmacy that incorporates automatic dispensing, but most importantly cuts the cost on drugs. There's psychiatric counseling and social work to assure that mental health is treated like any other issues that patients may have. Physical therapy is also offered, as is laboratory services to support the doctors. And finally, for those people who need it, transportation is offered for free. These three pictures show how the system grew from 1973, where it operated out of a two-story home, to the present, with a large complex that's shown in the bottom picture. It's a picture of the facility this spring, and a picture of the floor plan for the first floor. This particular clinic has 2 floors. The lower floor has a series of offices similar to what are shown as exam rooms in this picture, that are used for dental service and for dentists, and a waiting area for the dental area. It also has a dental lab and administrative offices and physical therapy. On this floor plan, you'll see that there are many, many exam rooms and stat rooms, which is the equivalent of an emergency treatment area, as well as doctors' offices and the social workers. The pharmacy is located on this floor, as are the lab and medical record areas. This slide shows the professional staff at the clinic this year. You'll notice that it has 4 doctors, it has 6 physician assistants, it has 4 dentists, as well as psychiatrists, social workers, people working on nutrition, psychotherapists, wellness coach, outreach coordination, and physical therapy. This is a list of services in the medical primary health care part of the clinic. It stresses family medicine, internal medicine. It deals with all sorts of health, including gynecology and pediatric and newborn care, and offers services for nursing home care and admissions and referrals to other facilities. Oral health is a big part of the community health care clinic. Well, this slide indicates they have 3 dentists. They currently have 4 dentists and 5 dental hygienists. And they not only take care of normal dental visits, but they also deal with bridges, dentures, extractions, crowns, root canals, and reconstructive dental care. Many of these services are prepared on site. This is a photograph of the dental lab that's in the clinic. Other services include social workers, psychology services, physical therapy, referrals to other facilities and agencies, nutrition services to deal with hypertension, diabetes, and cholesterol. Most important, perhaps, is that the health center is a medical home, a patient-centered medical home, which means that it treats all care as a partnership between the patients and the providers, meaning all the people who offer services within the clinic, both doctors, physician assistants, dentists, social workers, lab folks, and the patient is treated as in a team approach with all of those providers and staff. The center started out serving the entire community, those with insurance and those who had no insurance at all and couldn't afford to pay. As a result, during the last 40 years, the health centers operated with a sliding scale system of fees. So uninsured patients were always treated, but were required to pay what they could afford to pay. This is their 2013 budget and shows that they bring in about $7.5 million, 10% of which comes from funding from the federal government for people who are on Medicare and Medicaid. The expense side shows a similar number, about $7.5 million. The interesting feature about their budget is that there are significant savings in some areas. Malpractice and property insurance here represents about 1% for the malpractice part of the insurance. Typically in the industry, that number would be closer to 7%, or about $350,000 more than shown here. Other areas where there are savings are in the area of interest. The facility cost about $3 million to build, but the actual debt service for that facility is less than $200,000, or less than 2% per year. Other areas of savings are in the area of wages. Because there's high satisfaction between the professionals, or amongst the professionals in the clinic, the salaries tend to be about $15,000 to $20,000 a year less. The satisfaction comes from treating patients with more time, with more dignity, with more effectiveness, and using more time to do it. There is no marketing or development costs that are associated with their budget, as are found in many other facilities where there's strong competition to try to capture market share. In this particular budget, there are 70 full-time staff equivalents, 14,000 registered patients, 9,000 visiting annually, with 34,000 visits, and a cost per patient per year of $801 for all of those services listed, including lab work, dental work, and primary care. This is a summary. In 2013, $801 cost per patient. Facility and equipment cost was about $3 million. Compare that to what we're currently paying. In our health insurance policies that we purchase, we spend about $2,000 a year per person on primary care. So with this budget in this particular facility of $800, there's a savings of about $1,000 per person per year on primary care. Prescription drugs, which are part of the clinic, also result in savings. By purchasing drugs at the lowest possible brokerage level, we pay the least amount in profits to various layers in the system. By doing that, you can save between 75 and 90% of the cost of the drugs. Typically for us, we currently pay about $800 per patient for drug coverage for a year. The potential savings using this system are about $600 per patient per year. Between these two options, primary care is managed correctly and prescription drugs that are ordered with the least amount of profit margins built in, the savings together amount to $1,600 per patient per year, or almost $7,000 a year savings for a family of four. So let's go back to those cost elements that are in healthcare. Hospitals are not addressed by this particular view of how to deal with healthcare locally. Primary care is, and it's 50% of the cost of primary care is saved. That results in 15% savings overall in the healthcare system. Drugs on the left side of the pie, 9% of the total cost of healthcare can be saved by ordering drugs cheaply through bulk purchasing at the lowest levels of brokerage. The final piece is in savings in insurance, where it's restructured so that the savings go back to the ratepayers. In these examples that we've given, there's approximately 26% that's saved or available to be used for offsets as costs increase going forward. So, if we wanted to do something like this, what's the process and who do we need? Well, the process first starts with recognizing the problems. Problems are access. We need primary care. Quality. It needs to be care that's going to care for us and assure our wellness, not necessarily the greatest number of visits. And third, cost containment, so we can continue to afford health insurance. That's the first step. The second step is that we must take responsibility for our own healthcare system and for ourselves. The third step is to envision what we want in our community. What is it we think is important? And the fourth step is to make it happen. Who do we need to work with? Virtually everyone. Employees are under employee plans and patients. We need to work with the premium payers, which may include the employers. We need to talk with unions. We need to talk with local primary care providers, hospitals, specialists, nonprofits, insurance companies, and insurance pools, as well as federal and state regulators. This has to be a collaborative action to see if we can all together work to keep the cost down and keep the quality of care up. Based on this review, we ask you to add your voice to change the healthcare future in the Mascoma Valley. The next meeting will be June 18th at 7 p.m. at Mascoma High School Gymnasium. The task that night will be to list what we need or should do in Mascoma Valley. There will be a follow-up meeting in September to talk about what's possible, what will it cost, what will it take. But the first task on June 18th is to say, okay, looking at our own valley and our own 5 communities, what do we think we need here? What are the services that we need? What we would like to see in those services for quality? During the program that was held on May 21st, a number of questions were raised dealing with health care. What's good health care? What are our greatest wishes for good health care? What's great health care? What's bad health care? And what are our biggest problems with health care? 90 attendees from all 5 towns of the Mascoma Valley attended and shared their views with us. The following are the responses for each of the sets of questions. The first one is, what's good health care? The second set of questions revolve around what is bad health care? What don't you like? What needs improvement? What keeps you from getting good health care? We know the problems. Healthcare and insurance costs are increasing too fast and too much. Fewer people are insured. Fewer are receiving care. There is less local and personal service and less consumer voice. Add your voice to change the healthcare future in the Mascoma Valley. The next meeting is June 18th at 7 p.m. at the Mascoma High School Gymnasium.